For that, let's pivot to John Mascarenhas on current and emerging JAK inhibitors for myelofibrosis.
All right, Ruben, thanks very much. Thanks for for setting us up for this discussion. I'm going to be talking about current and emerging JAK inhibitors in MF and cover the emerging data from ASCO, EHA, moving into SOHO. And I think it's important for the audience to understand that there are now 4 JAK inhibitors that are approved for myelofibrosis in the U.S., listed here: ruxolitinib, fedratinib, and pacritinib, and then most recently, momelotinib. They all share one thing in common: they're JAK2 inhibitors, but there are differences and nuances in their kinome profiles that likely explain different niches, different toxicity profiles, and the opportunity to even use these drugs in sequential fashion. So right now, ruxolitinib remains the main JAK inhibitor of choice, particularly in the upfront, but fedratinib is a great drug for a second-line agent, particularly to capture spleen responses, and pacritinib has captured the area of thrombocytopenia and the cytopenic myelofibrosis phenotype, with momelotinib as a drug now that can be used to improve anemia in patients that have ongoing anemia, which Ruben has illustrated remains a burden not just to the patient, but also to the healthcare system in general. I will note that there are JAK inhibitors that are still in development, despite the fact that we have this plethora of available JAK inhibitors like itacitinib, the selective JAK1 inhibitor, and then jactinib, which is a JAK1/2 inhibitor that's been mostly developed in Asia and China, and we'll review some of the emerging data on that agent as well. So the first abstract I'm going to highlight today is an abstract that capitalizes on a theme that has been seen with other JAK inhibitors, namely ruxolitinib, which is the impact of spleen response to an endpoint that matters to patients and physicians, which is survival. So this is looking at data from PERSIST-2, which was the pivotal study that led to the approval of pacritinib at 200 milligrams twice daily, and comparing those patients that were treated at 200 twice daily to BAT in terms of those that had a response, which here was a spleen response of at least 10% or greater at 12 weeks, so at an early time point versus not having that. And what you'll see in the box on the left is, in general, there were some differences between those patients treated with pacritinib that had a spleen response. They tended to have disease other than high-risk disease, tended to be less transfusion dependent. They were equally patients who had seen prior JAK inhibitor and not, which is an important observation. These patients had large spleens, but sort of not surprisingly, or maybe surprisingly, had those that responded had even larger spleens than those that didn't respond. The point of this analysis was that at 12 weeks, one could see an association between spleen response with pacritinib and survival that wasn't seen with BAT, which again was mostly ruxolitinib in those patients that responded. And if you try to look at what was the minimum threshold of response at 12 weeks in terms of spleen response that correlated with survival, it was a minimum of 10%. That's where you had the best separation between the survival curves, as shown in C down below in green with pacritinib, and that was not true with BAT. So interestingly, there is an apparent survival benefit with spleen response, even with a minimum threshold of 10% reduction at 12 weeks with pacritinib, that wasn't also seen with the BAT arm, which again was mostly Rux in the responders at low doses, sort of making the point that there's a likely mechanistic difference between these two agents that leads to this response and improved survival. Perhaps the fact that it's an IRAK1 inhibitor and it's also an ACVR1 inhibitor, and that might be the differentiating factor here in the cytopenic MF patient population. If you drill down a little bit further, again, I made the point that it was mostly the Rux patients that responded of at least 10% with SVR, despite the fact that that didn't seem to correlate with survival. And then if you look below, the investigators also pointed out that this correlation between spleen response and survival was really only discernible in the context of measuring the spleen response by imaging, so spleen volume response. When looking at it by palpation, which is not as rigorous of a way of evaluating spleen response, it was really lost. You couldn't really appreciate a statistically significant difference between a spleen response of 20%, 35%, and 50% by length reduction and survival. So although nominally it was there, and the green bar, the green curve demonstrates pacritinib has a survival better than BAT, it was not statistically significant using spleen response palpation. Perhaps at 20% was a little bit better. What about looking at spleen and symptoms as a function of baseline blood counts? So this is a pooled analysis from PERSIST-1 and PERSIST-2. So taking all the patients that were treated both in the upfront second-line setting, irrespective of platelet count, and looking at the various depths of spleen response and symptom improvement, and then stratifying them by baseline platelet count or hemoglobin on top. And what you can see is, no matter which way you look at the patients, the spleen response and symptom response in each category was consistent across the different baseline variables. Perhaps the one exception I'll point out is that if you look at TSS 50% or greater, that was actually the highest in patients who had hemoglobins less than 8. These patients who have quite cytopenic disease and anemia as a feature of that profile actually, interestingly, had the best benefit in terms of TSS 50. The bigger take home is whether you're looking at spleen, symptom, or even PGIC, the responses were consistent across the patient profiles as it relates to baseline cytopenias. Now, if you look at survival, this is an interesting an analysis. That was a prospective phase 2 study done in Germany, looking at patients who were intensively treated with pacritinib by design 1 month prior to a reduced intensity conditioning transplant for myelofibrosis using fludarabine, busulfan, and ATG. And although they enrolled about 68 patients, it was about half those patients actually ended up getting the transplant. So patients fell off for various reasons. Some of the patients were transplanted off study. But the point of this study was to determine whether there was an additional benefit of a JAK2, IRAK1, ACVR1, FLT3 inhibitor to reduce the inflammatory signaling that is characteristic of MF in order to improve upon engraftment and graft versus host disease. Similar studies, both prospectively and retrospectively, have been conducted with ruxolitinib. So it is a value to see whether an alternative JAK inhibitor that has a slightly different profile may also provide similar or even improved benefit in this setting. And what the investigators saw in this phase 2 study was that there was reduced incidence of both acute and chronic, both moderate and severe GVHD in this setting compared to historical controls. And you can see the survival curve here of these patients that were transplanted, and these are, of course, advanced patient, would suggest a median survival at a follow-up of about 33 months that had not been reached, with the GVHD-free survival that also looks relatively positive, again, compared to historical controls. This is a very difficult disease to transplant, and as Ruben and Prithvi know, patients who go to transplant with MF are often complicated by poor engraftment, GVH, and other complications. So trying to improve upon those outcomes with a JAK inhibitor like pacritinib is an interesting and important clinical investigation, and more data is needed to fully understand the full benefit and the long-term benefits of pacritinib prior to transplant. But this data set was interesting and is prospective data. Here I'm showing you an abstract from Dr. Masarova, who works with Dr. Bose at MD Anderson, using a MAC analysis, which is a matched-adjusted indirect comparison. So basically taking patient-level data from one trial and comparing it to aggregated data from other trial, and adjusting for variables by weighting the variables with statistical methods. And here we're looking at patients who are JAK inhibitor naive. So from the SIMPLIFY-1 study with momelotinib versus fedratinib in the Jakarta study, and then on the right, those patients are JAK inhibitor experienced, so a composite of SIMPLIFY-2 and the Momentum study patients with momelotinib and Jakarta-2, which was the phase 2 study of single-agent fedratinib. The point of this analysis is are there differences when comparing across these trials in terms of the incidence of thrombocytopenia and other non-hematologic toxicity with fedratinib and momelotinib. And if you see the superscripts A indicate in those areas that are statistically significant, but in each case, momelotinib did appear to be, in the SMAC analysis, associated with less thrombocytopenia, diarrhea, nausea, even serious adverse events, and adverse events that lead to discontinuation and importantly, dose reduction, and grade 3/4 adverse events. And this was true both in the JAK inhibitor naive space as well as those that are JAK inhibitor experienced, suggesting that momelotinib has a favorable toxicity profile when comparing this drug to fedratinib, which of course has caveats when comparing across trials. The MAC analysis is hoping to try to accommodate those variables that do exist and confound such analyses. This is a really interesting abstract presented by Claire Harrison and colleagues. So this is a sort of a different way of looking at anemia and the impact of therapy on anemia. Here, this is from data from a translational phase 2 study of patients treated with MF treated with momelotinib. And this is like a shift plot. So on the y-axis, you're looking at the baseline transfusion intensity. So this is units per cycle of transfusion, and on the right, transfusion intensity during the treatment period. And what this analysis shows us is that with momelotinib treatment, there is a shift and a reduction, at least a stabilization or reduction in transfusion burden in 90% of those patients that are treated with momelotinib, suggesting that even in the absence of transfusion independence, that there is at least stability or reduction in the transfusion burden across time during momelotinib treatment. And one of the points Ruben made in his previous presentation, which I think is even relevant here, in terms of the healthcare resources allocation and costs associated with transfusion, was that perhaps there wasn't such a huge difference between those patients that become transfusion independent versus those patients that still are transfusion requiring. But this analysis would suggest that you can reduce the amount of transfusions with momelotinib, even in the absence of not obtaining transfusion independence, and perhaps that does have a benefit to patients overall. And that's what this abstract is trying to show from a different angle. So this is looking at transfusion-related costs offset and time burden in patients with myelofibrosis that were treated in the Momentum study, comparing momelotinib to danazol. So this is not really asking questions about how patients feel or their performance status or their impression of change. It's really looking from a financial and time perspective, which is not unimportant, with the idea that anemia is a burden to the patient, to the healthcare system, and a financial burden. And if you look at the U.S. Dollars, so up on top, the total medical costs, so TDs, transfusion dependent, TBTRs, those patients who are transfusion independent or transfusion requiring, you'll see that with momelotinib compared to danazol in each case, there are less U.S. dollars associated, both in total, but also as outpatient transfusion costs than danazol, and even less if you can achieve a reduction in your transfusion burden, suggesting that there's a financial, I wouldn't say gain, but less financial toxicity perhaps, if you can even reduce the amount of transfusions someone is experiencing in the course of myelofibrosis. And of course, not surprisingly, also less time needed in transfusion suite, which is a real burden to the patients and their family members if they're constantly being transfused. So reduction in costs and reduction in time burden with momelotinib compared to danazol in terms of anemia benefit and transfusion burden. So I'll finish up here with jactinib. This is the next JAK inhibitor that's remains in clinical development. It's a JAK1/2/3 inhibitor, also inhibits ACVR1. There are 3 studies in which it's being evaluated, both in the upfront setting and in the relapse refractory setting. And I'm going to show you some of the data today from intermediate 2 and high-risk patients who are JAK inhibitor naive. 47 of which received jactinib and 23 received hydroxyurea. Again, this was done in Asia. We would typically not use hydroxyurea as a control in this country at this point. And this is a patient population that I think most practitioners could relate to in terms of the demographics. Spleen volume is not as large as some of the other studies with patients who've been previously treated, but you can see the mean hemoglobin was 9.2 and platelet count 239. And what we see here is that at 12 weeks and 24 weeks, there's significant advantage of this novel JAK inhibitor versus hydroxyurea in terms of spleen volume reduction of 35% or greater. In fact, 72.3% is probably one of the highest SVR rates I've seen at 24 weeks with monotherapy JAK inhibitor, and that definitely caught my attention. That was significantly more than the 17% seen with hydroxyurea. Symptom improvement was also superior with jactinib versus hydroxyurea, particularly at week 24 with 83% versus 43% symptom improvement. And there wasn't one specific subgroup that was really driving this. This was seen across the different subgroups of patients that were treated on this trial, favoring the JAK inhibitor versus hydroxyurea. I mean, this was relatively well controlled, with well tolerated, with grade 3-4 rates of thrombocytopenia and anemia and leukopenia with the jactinib of 17, 25, and 2%. So not a lot of toxicity, perhaps even a benefit in terms of less anemia than one would expect with, for example, ruxolitinib. So this becomes an interesting agent that, again, has been developed mostly outside of the U.S. Even in the second line setting, we see pretty good and pretty comparable spleen and symptom improvements shown here. So SVR 35% rate of about 32% in the relapsed setting, with 43% in those patients who were previously intolerant to ruxolitinib. So second line agent with very significant symptom improvements as well. So providing a sense that there may be another option here. Maybe I'll pivot for a second to Ruben and Prithvi and ask the question. We're blessed here with 4 JAK inhibitors that are approved in the U.S. Is there room for a 5th JAK inhibitor, and where would we use it?
I think these data overlap to a significant degree. I mean, I think to be transparent, I think this drug was developed in China to have an in-country alternative to spending lots of money on foreign JAK inhibitors. So I think part of the goal of these studies really has been to demonstrate non-inferiority to perhaps compete with the other JAK inhibitors in other parts of the world. But that said, I think as we, see longer term data, we'll see if there's any differentiation. I think their comparison against hydroxyurea, it was kind of a weak comparison for the trial.
Yeah, agreed. All right.
I agree, Ruben and John. Like you said, there is it's a little difficult to extrapolate these data to our scenario here. But I think moving on perhaps from this, there is going to be interest in the JAK2 mutant specific inhibitors that some companies are developing.
Yeah, agreed. I mean, we're moving into an era where we're now actually developing molecularly defined therapies, which is pretty exciting. But having a wealth of JAK inhibitors available to us to individualize for our patients still remains a really good position to be in.